Pete's sake. All right, paralytics. We have depolarizing muscle relaxants and non-depolarizing muscle relaxants. And by the way, if you see me seeing muscle relaxants, I need paralytics. I'm an anesthesiologist. Anesthesiologists, we call it muscle relaxant. In fact, in the book, it's called muscle relaxants. That's the chapter. When I say muscle relaxants to other people, they say, "You mean baclofen?" No, I think it's a misnomer. It is supposed to be called paralytics. So paralytics are divided into depolarizing and non-depolarizing, and it all depends on the mechanism of action. The depolarizing is the way it works is this is the motor end plate, this is the nerve ending, and basically by the motor end plate depolarizing all of the all of the muscles, so depolarizing the motor end plate, resulting in depolarization, which results in action potentials. The muscles start to move. The only medication here is succinylcholine. Let me just write it here, and then I'll draw this again. Succinylcholine. Succinylcholine. The other medication was called dexamethasone or something that was taken off the market. This was like the second generation after Curare or something.
Curare is on the other side.
Is on the other side. So, how does it work again? This is the nerve ending, and there is a lot of acetylcholine vesicles in the motor end plate, in the nerve. And when the impulse comes, these vesicles devesiculize, rupture, go close to the wall and rupture, and stimulate receptors in the muscle membrane here that are sodium, potassium, these receptors use a sodium potassium ATPase pump. So that pump actually uses energy. And what it does, it kicks potassium outside the cell and gets sodium into the cell, and then you start having action potential. So that's how regular contraction happens. You can see now that the potassium will rise a little bit with giving one dose of Sux. So normal people, if we give you 100 milligram of Sux, your potassium will rise by a factor of 0.5 milliequivalent or something. All right, so succinylcholine, this action here happens happens very quickly, and all of the muscles of the body, if you give succinylcholine is a chemical analog of acetylcholine. It's very similar. So it seeps everywhere. It seeps also in the nerve endings. So succinylcholine goes everywhere in the body. So the 100 milligram that you're giving, the nerve endings get at the end maybe 10 milligram or something, or less than that, right? So it makes it to the nerve endings, and the nerve gets confused. It says, "Oh, we have a lot of acetylcholine. Let's devesicalize." So devesicalize all of the vesicles, and after it gets rid of all of its acetylcholine, it ends only with succinylcholine and says, "Oops, I have only a succinylcholine. I got fooled." So after this amazing contractions of all the muscles of the body, you have a period of paralysis. You can't contract anymore, right? So that's the way it works. The muscles contract, all of them contract at the same time, and that's why they call it fasciculation. Because if the biceps contract and the triceps contract at the same time, the final movement is like this. None of them is moving. If you go to the gym and you're overdoing this, we see people doing like this as they're fasciculating, because I can wake you up and say, you gotta work on your triceps. I saw your biceps contracting. Women, they only contract here and here, eyes and mouth. Notice that for me. If you give sex for women, eyes and mouth, nothing else contract. Most of them. The strongest muscle. and the eyebrows. So anyway, so this action causes paralysis in about what? So the onset of action is 60 seconds. the duration of action, how do we come out of this predicament, right? When there is no vesicles here and only succinylcholine is here, then there is less succinylcholine outside, there is a concentration gradient, then it starts to seep out into the plasma. And when it seeps out into the plasma, there is an enzyme called pseudocholinesterase. And that breaks the sucks. So cholinesterase breaks the acetylcholine, and pseudocholinesterase breaks the sucks. So it keeps on eating the sucks, and the concentration gradient continues until there's no more, and the nerve now has time to make new acetylcholine vesicles. That takes about 10 minutes. So that makes succinylcholine suitable for intubations. Great for intubation. It gives you intubating conditions. It relaxes the muscles here. It relaxes the muscle of the jaw. All of these muscles, and make it very easy to intubate. But also, if you couldn't intubate the patient, you can wake him up in 10 minutes. So that makes it perfect for that. But despite that, I can tell you a statement that I do, that I used to do, but I'll tell you why I don't do it now, just out of. So, that all of my patients, when I give anesthesia, or most of my patients, when I give anesthesia, I give them sucks. And most of my patients, when I intubate in the ICU, and now I can change the statement and say maybe 40% of the patients that I intubate in the ICU, I don't give them sucks. Right? Why? Because sucks has a black box warning that it causes hyperkalemic cardiac arrest. So cardiac arrest due to hyperkalemia. Remember we said it raises the potassium a little bit? So that's what makes it a little bit more difficult to do it in the ICU. And there is another reason, obviously, is that when it's a teaching hospital and stuff like that, you don't wanna you paralyze somebody. The first attempt is the best attempt, and then after that, the patient is hypoxic. It means completely different when you're breathing on your own and can actually regain or maintain some of your oxygenation. You have more trials to do. Each trial, intubating somebody that is non-paralyzed is actually more difficult, but at least you have 8 of those trials. You can keep trying and intubate. Intubating somebody that is paralyzed, it's easier. But then once you failed once or twice, patient now is hypoxic, you have to ventilate, now he's vomiting at you or regurgitating, and that's it, and the end of story. Or he's hypoxic and you can't bring his saturation up using a mask. So we're moving directly down the algorithm to a crike or something, because you paralyze the patient. So paralysis of the patient makes the first attempt easier, but also makes it. Okay, now with COVID, this changed, because we had to do all of our intubations with paralyzed, so we had to find a way. And then with something else that another change that happened made it even easier to do it. So again, let's go back to where we are with hyperkalemic cardiac arrest in sucks. So does it happen to everybody? We give sucks to everybody. It doesn't happen. So it happens mainly, it was discovered in patients with Duchenne muscle dystrophy. And people with Duchenne muscle dystrophy have something they call it immature receptors, and these receptors just leak potassium out. So the potassium will go from 4 to 8, and the patient will have a cardiac arrest. So you have to avoid it in Duchenne muscle dystrophy. So you see the anesthesiologist going to the kids, especially males, because it's X-linked, say, "Do you play soccer? Do you play football? Show me how." Whatever. If you're around 10 years of age or whatever, and a male, you're scaring the anesthesiologist, because of Duchenne muscle. Very rare. Anesthesiologists love zebras. But then they found it also in all of the other muscle dystrophies, Becker's muscle dystrophy and limb girdle muscle dystrophy and all of these things. So all muscle dystrophy sucks should be avoided. In fact, there was a patient with ALS. It hasn't been described in ALS, or maybe it has. One of our colleagues here, like 20 years ago, told the resident, "I think sucks is contraindicated in ALS. Patient is in. I'm gonna use it anyway. I don't know what else to use." So He used it, and the patient had a cardiac arrest. Of course, came, they brought him back, but disaster. Anyway, so good. I'm gonna use sucks in the ICU or in the ER, but I'm gonna avoid these types. But then they found it in paralyzed patients. So anybody who has paralysis, like hemiparalysis, paraplegia, quadriplegia, all of these things, these muscles, they don't have immature receptors, but they over-regulate these receptors. They start making more receptors here to receive any impulse, and that increases the number of potassium outside the cell. And then they discovered it in bedridden patients. Now it's becoming more difficult. Somebody comes from a nursing home setting, they behave like a paralyzed patient. They over-regulate the receptors. And then it became even more difficult because they discovered it in burn patients. So if somebody has a burn more than 30 degrees of the body surface area, and from 2 days up to 2 years. Who comes up with this? Again, some case reports, like the last thing we talked about, case reports. I don't want to be the first one who's recording a case report at 3 years. So you have more than 30% body burn. I'm not ever giving you sucks. You're allergic to sucks in my world, right? And that's because the burned skin, develops some receptors that receive sucks and actually secretes potassium without contraction, obviously. And then it starts to come close to home now. Renal failure. Patients with renal failure, they actually can have, increase in the potassium, and that can be the straw that breaks the camel's back, and that's it. You're done. So becoming a little bit more difficult to do in the ICU, but the one that really scares me the most, that made me absolutely cannot do sucks or don't like to do sucks in the ICU. Of course I do it, but be careful about it. Is acidosis. When I'm intubating somebody, I'm probably intubating him for acidosis, or hypoxia and acidosis, or something like this. And if you're acidotic, the potassium and the hydrogen exchange across the membrane almost instantly. So if I give you dilaudid now and your potassium is 4, I don't need to measure the potassium. I know the potassium is going to be high. If you stop breathing, your potassium always exchanges with the hydrogen. And then you give the sucks, then you can cause a problem. So that's why we try to avoid it in the ICU as much as possible. But there's some certain cases you have to give it. For example, gastric outlet obstruction. You're gonna touch the back of the throat, they're gonna vomit at you. Or somebody with increased ICP, so you don't want him to buck and cough and do Valsalva, that will actually raise the ICP and make him herniate. Somebody with an open eye or open abdomen or open skull, for that matter. You don't want to give this sucks for. You don't want to do without sucks, without paralysis. Let's say you have that and you have one of those. So, and he's also acidotic. So you don't want to give sucks. So there's only other option that you can do, which actually helped us a lot in the last 5 years or so, is, this drug is there for a long time. But I'll tell you how it helped us, is rocuronium, which we call the rock. The rock. And if you know the name, the trade name is Zemiron. I don't know, because the trade names, you have to put Z or X. All the trade names, in order to sell it, have to be Z or X. The rock is better than anything. We made the trade name for it. So how does it work? The rocuronium is one of the non-depolarizing. The other thing, it works by competitive inhibition. It's a moderately acting non-depolarizing muscle relaxant, and it works by just competitive inhibition. And the dose is 0.6 milligram per kilogram, IV times 1. But that gives you intubating condition in 2 to 3 minutes, not 60 seconds. So that means you're gonna wait for a little bit longer time. The patient might become more hypoxic. All of these things. If you double that dose, 1.2 milligram per kilogram, it gives you intubating condition in 1 minute. So that's why we can use the rocuronium. Unfortunately, that gives you a duration of action of 2 hours. This dose gives you a duration of action of 2 hours, so you're committed, you're married to that patient. You give him the rocuronium, you have to secure an airway here. Right? Questions? So anyway, so that's how we give it. So we had this drug for about, this drug has been around for 15 years or so or more, and we always use it in cases like this. But we just we be careful. 2 hours until what came out? The Sugammadex came out. The Sugammadex actually resolved a huge issue here. And Sugammadex was in Europe for 10 years, and we were salivating over it before the FDA finally approved it here. It's an expensive medication. It's in the thousands of dollars. And it's an antibody against rocuronium. So the way you reverse these muscle relaxants is by, cholinesterase inhibitors and stuff like that. No, this one is by just antibody to the rocuronium. So it's very specific to rocuronium. It doesn't reverse any other medication. And you can reverse it anytime, right? When we talk about the reversal of muscle relaxants, you'll see that the reversal, basically, you have to reverse them when the action is almost done. You can't reverse them in the beginning. So I can't give rocuronium and give, neostigmine immediately after. It's not going to reverse it. It's reverse it only if I have twitches. So all of these things are important factors. Sugammadex is beautiful, but you have to have it in the area that you're using the medication. If you have it in a pharmacy, that's not a good idea, because by the time somebody gets it, you're done, right? So that's rocuronium. Now let's talk about the non-depolarizing muscle relaxant. There are 2 classifications for them. Short-acting, mivacurium. Moderately acting, we talked about rocuronium, most of them, and long-acting, pancuronium. There is another classification, steroidal or non-steroidal. Like it has a steroid ring or doesn't have a steroid ring. And that's important because we incriminate these muscle relaxants in causing what? Myopathy. So when we talk about steroidal muscle relaxant versus non-steroidal, the rule of thumb or the prediction without big studies is actually is that steroidal muscle relaxants cause more myopathy than non-steroidal muscle relaxants. Right? It makes sense, but nobody did a big study on that. Let's talk about the 4 muscle relaxants that were used as drips in the ICU. So these 2 we used for intubation. I used that as a drip. It was a horrible mistake. Not mistake, but because we didn't have the others, there was a national shortage, so we had to use it as a drip. Rocuronium is known for individual variability. So you use it, there's no prediction when you're going to wake up. And it did happen to that patient. And I think we didn't have the Sugammadex at the time. So the 4 muscle relaxants that we used or use in ICU. The first one is pancuronium. The other name is Pavilon, pancuronium, right? Pancuronium is literally one of the curare and then pancuronium.
Not available right now in the US, right?
It is available. I used it actually when I used it exclusively during my residency actually, and then towards the end of my residency, that's the dark ages, my residency 20 years ago. But it's still available, but no hospital buys them anymore. Like you don't find it in this hospital. It's not formulary. But if I want pancuronium, I bet you I can get it. It's some pharmacy.
I thought that at some point the European manufacturers stopped selling to the US because we were using it for lethal injections. Like over the last 7 years.
Is that why?
I think that's why.
But we were using it for anesthesia.
Right, but it's only manufactured in Europe, and then
okay, so we use pancuronium for the so any medication that I want to kill now, I use it for lethal injections. I love it. Wow, amazing. You always come up with the legal part of things. All right, so that could be, but I've seen this drug all the way to 15 years ago. So who knows? Maybe then they. Okay. So what's the problem here? Number 1 is long acting. So if you infuse it for a day, you may be paralyzed for another day without drugs going on. Number 2, the doses, I'm going to tell you the doses later, it's very easy. Long acting, right? Number 2, it's actually metabolized or excreted by the kidneys. So if patients have renal failure, it could be a problem. Number 3, it's vagolytic. So if you give the induction, the big dose, the patient becomes tachycardic. Number 4, it's steroidal, so it can cause, and it did cause myopathies in people. Number 5, it's refrigerated, and that's a problem with all of those medications. Most of them are refrigerated, and I don't care what your arrangement in the hospital is. Refrigerated medication is always a problem, because a new nurse comes in and says, I can't find it in the Omnicell, because she's not reading that you look in the fridge behind you or something like this. Or somebody keeps it in pharmacy or in ICU on the shelf, and then puts it in the fridge after a month or so. Then now it's cold and nice, but it doesn't work. So all of these refrigerated medication could be a problem. Now in the late 80s and early 90s, a drug called vecuronium came out. There's actually, the other name is Norchiron. I don't know why narcotics is involved here, but Norchiron. And it's moderately acting, so a little bit shorter acting than, and this is still available, obviously. It's metabolized by the liver, so it's not excreted, doesn't depend on the kidney. So more patients are able to take vecuronium than pancuronium, right? Because more patients have this than this. Number 3, it's cardiovascularly inert. If you inject it, as if you're injecting water, nothing happened to the patient. Number 4, still steroidal, so that's still a problem. And most of the bad rap about muscle relaxant happened from these two. If you read case reports, either vecuronium or pancuronium was used, and the patients had, myopathy. But number 5, and the thing that made this a star, and we still have it till now, is it's the only muscle relaxant that is non-refrigerated, and it comes in powder, white powder. It comes in with a water, sterile water diluent for it, and you have to take it in. You don't have to do water, by the way. If you're in a rush, LR, normosaline, D5, LR, anything, just dissolve it in something. And if you dissolve medications for a living, like anesthesiologists and nurses, medications actually, the rapidity of the medicine dissolving is actually a huge factor in using the medication. Give me an example of medication that takes forever to get dissolved.
I think TPA is a pain in the ass to prep.
TPA is a pain in the ass. If somebody takes the TPA and does like this, you can't use it anymore. It makes a huge amount of foam, right? So they have to like... Okay, so it's a pain in the ass in that part, but it dissolves relatively quickly. Dantrolene, you have to have like 2 nurses doing like this for like 20 minutes, and the patient is dying. They made a new dantrolene now that is much better. And of course, cefoxitin, oh my God. Stuff like that. But this one, instant. You put the thing, it dissolves. So that's beautiful, So that was the drug of the 80s and early 90s until atracurium came out. Atracurium is a medication that is still moderately acting, but a little bit shorter acting than vecuronium. Number 2, it's not metabolized by the liver or the kidney. It's metabolized by something called Hoffman's elimination. So if you don't have Hoffman in your blood, you're not eliminating. Hoffman's elimination basically when they don't know how it's broken, they say non-specific esterases, and basically it just breaks itself. The drug breaks itself in the plasma, so in 20 minutes it's gone, or 30 minutes. So it's amazing. For ICU patients to have something that doesn't depend on the liver and kidneys, amazing. Number 3, unfortunately, it causes histamine release. So if you inject a bolus, it can drop the blood pressure or give you some hives or something, like morphine. Number 4, and that is the kicker here. That's why this medication is all over. It just stole the thunder from vecuronium, it's the first non-steroidal muscle relaxant. So a lot of people went this direction in the 90s. And then, of course, number 5 is still refrigerated, like the rest of them. Okay? So that happened until, and this, by the way, this predated the pharma laws. So I was there before the pharma laws, which companies could come to you, and the only thing they talk to you about is how bad the competitor is. They could do that. So we would see the vecuronium company coming to us and giving us leaflets and blah, 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 brochures and everything about a compound that comes out due to the metabolism, the Hoffman elimination of atracurium, and it's called lodanosine. Lodanosine. I call it the lodanosine scare. And when lodanosine was taken, and separately from atracurium, just lodanosine, syringe filled with lodanosine, injected into a rat, the rat seized and died. So basically they said, this drug gives you a neurotoxin and it should not be used. And people heard this and just started going back in the opposite direction towards vecuronium. Until the cis atracurium came out, which is the cis isomer of atracurium, which basically kept all of the good effects and avoided all of the side effects. So there's no area in medicine where I can tell you that this is the medication to be used. There's nothing else to be used for drip in a patient. So it's still moderately acting, still Hoffman's elimination, no histamine release, still non-steroidal, still refrigerated, and no lodanosine, or very minimal lodanosine. So this became the drug to be used. So we, in our practice, we use this as a drip, and we use this for boluses. Why is this for boluses? And this is the only one of muscle relaxant that is present in the intubation kit. We have a bag that has all the intubation drugs in it. This can stay outside the fridge. So this is the only one I can keep outside. So that's present in this bag. Bless you. And but I can't put any of the others. So that's why this serves a huge purpose. This serves also a huge purpose. I never give this a drip, but I have to give this as a drip. That's why when you see us going to the MRI, we do what? VMV. What's VMV? Valium and vecuronium. We don't have a pump that is compatible with MRI. So what are we gonna do? Valium 20, vecuronium 10, or 10 and 10. Valium 10 and vecuronium 10. They last almost the same amount, and the patient will be paralyzed, and they have to switch into pressure control and go to the MRI. If somebody's like hypoxic or whatever, and you don't want to commit him to a drip, or you want to see the effects of paralysis, if I come up with this from this talk, that inserting something in your brains, guys, is that paralysis is okay. It's not too dangerous to be used. I'm sure you guys use it all the time, but if somebody's hypoxic, just think paralysis first. Paralyze them, control the situation, pressure control, everything is fine, and then you can unparalyze them. You don't have to commit them to a drip. Okay. The doses are 10, 10, 10, and 50. So it's very easy. That's the bolus that you give. Of course, sometimes I give 20 here, but it doesn't matter. Sometimes I give 20 here. But 10 is the usual dose, and when you give 10, usually they last about maybe 45 minutes to maybe 1 hour and a half or something. Depending on the patient. The drips, 2 to 10 mics per kilo per minute, and that is titrated for a train of 4. So a train of 4, that's the way we titrate muscle relaxants. And you have to familiarize yourself with this machine, because sometimes the nurses will just freak out about it. And there's a nursing practice that we should debunk and just get rid of. If a nurse comes from the ICU down in the ER, for example, and work with you guys, or somebody transfers from ICU to ER to work in the ER, or you're in the ICU, what's going to happen is that the classic teaching talks about finding out what current does the patient contract on, and then using that current for the whole duration, which is never done by anesthesiologists. It's a horrible way to do it, and it delays the injection of the muscle relaxant. If you need the muscle relaxant, you need it right now. I don't care what happens there. The anesthesiologists go to maximum current all the time, right? Because by the time you're 2 days into the ICU, this thing becomes edematous, and you need the maximum current anyway. So how do you familiarize yourself with the machine? Because when the nurse should tell you, come and troubleshoot the machine, you have to pretend this, I'm familiar with this machine, right? The machine there's 2 types. One, the most common, looks like this. This one is TW, this is TOF, train of 4, this is 50 millihertz, and this is 100 millihertz. And basically the only 2 that we're using is this and this. And the current comes from the side here. You turn the current all the way up to 10, and that's it. You don't change it after that. And the either comes with 2 prongs like this, and you put the 2 prongs on the nerve, but that's, and then you can remove it, or it's attached, these 2 prongs are attached to EKG electrodes, and you put the 2 electrodes in. It doesn't matter where the positive and negative electrodes lie, as long as they're close to each other here. They don't have to touch each other and should not be touching each other. Should be a distance in between, and it's actually you're stimulating the ulnar nerve. Why did we choose the ulnar nerve? Because the ulnar nerve has a specific muscle and specific movement that is different than all of those movements. So if you're stimulating the tendons here, if the current encroach on the side here, you're stimulating the tendons, and all of the tendons are going to contract anyway. So you're not testing anything. But if you are here, you're stimulating a nerve, and that nerve actually crosses like this and stimulate the adductor pollices. So you're actually looking at the adductor pollices movement. You're not looking at those. So you're stimulating the ulnar, looking at the adductor pollices movement. If you do it to a normal person and you press the TOF, they're gonna contract for 4 times. And if they contract for 3, that means 75%, or and then contract for 2, that means 2 out of 4, 1 out of 4. The literature uses percentage. None in anybody clinically uses percentage. Everybody uses 1 to 2 out of 4. The goal is to have a train of 4, 1 to 2 over 4. Less than that, that's over. Too paralyzed, too much, and more than that is too awake. So now you're being called in the room because the patient is. They're pressing the train of 4, and they are on like 2, the lowest, and the patient is still not having train of 4. They're pressing the button, nothing moves. So do you want us to stop the drip now? So very easy. You just go and assess how the machine is working. Is it working or not? You look to see, is the patient doing like this or like this? Then the machine is not working. That's the easy one. Or you look at the vent. Is the patient breathing over the vent? Then the machine is not working. Or you look at the BIS monitor. If the BIS monitor have EMG on it, that means the muscles here are moving. Then the machine is not working, right? If all of those don't exist, and you think that the patient is not moving, then you press the train of 4. Of course, there's no movement. Then you press the 100 millihertz, which is called tetany, and that causes tetanic contraction of everything, including the paralyzed muscle. So if the muscle is paralyzed, that's too much current. It will contract, right? So by doing that, you're making sure that your machine and circuitry is working, and then if still with 100 millihertz it did not contract, then that means the machine is not working. Either machine is not working, wiring, whatever, and if everything is checked, you can move it to another nerve here, the facial nerve, coming from the tragus of the ear to close to the cancers of the eye, and looking at the orbicularis oculi movement. Right? So that's the most common. There's another one that they call this DBS, double burst, and they call this TAT, tetany. So whatever machine you're using these 2 on the side here, TOF and tetany. DBS is proved. Studies show that it's better than tetany. Nobody uses it. All right. So anyway, so that's your assisted requiem. Okay. Last thing is studies. Basically, what are the 5 advantages of paralysis in a hypoxic patient? Number 1. 2 here together, we call them decrease metabolic demand, which is what? Decrease oxygen consumption and decrease CO2 production. Another 2, increases compliance of the patient, which is what? Allowing the 2-to-1 inverse ratio, and decreasing auto-PEEP. Because if you're breathing spontaneously, you're probably going to have auto-PEEP because you're tachypnic. And then the last one, improving compliance, right? This is compliance with the vent, I guess, but this is improving the compliance of the lungs, which is basically increasing the tidal volume per pressure that is given because you're paralyzing all the muscles, right? So that's
so the top compliance there is when people talk about vent synchrony.
Yeah, I'm gonna say synchrony.
Cooperation with the vent.
Yeah, synchrony, not compliance. Right, so decrease metabolic demand, synchrony, and improving compliance. And each one of them has 2, except the last one has 1. So 5 advantages of paralysis in hypoxic patients. The studies, case reports in the past, these were all negative because they're just showing myopathy. So people got scared of it. Then a group in France actually did a pilot study using cystic requiem in ARDS patient, and all of them survived. There was like case series. And then the same group did a study on patients with less than 150 PF ratio, ARDS patient within 24 hours of diagnosis or intubation, and they actually showed mortality benefit. But as any other statistical snafu, the mortality benefit was like 28 days later. The mortality benefit was the same between the cystic requiem and no paralysis. And then suddenly widened 28 days later. So people say that's a. They did a bigger study. They showed no difference between paralysis and no paralysis. For me, I don't care. I'm a straight line. I've been using paralysis for the same indication, whether the studies show yes, no, for the sake of my own patient. This thing work. It prevents the death of hypoxia, and as you know anything about the ICU, we really don't know a lot about our specialty. It's a young specialty. All I know is that I want my patient to survive this shift. And if everybody does the same, the patient is going to survive eventually. So give him the paralytic until we do the CVVH. Give him the paralytic until we do the X, Y, and Z, the ECMO, whatever. But you don't give the paralytic because the study said don't give paralytic, then you're an idiot. If you give paralytic, some idiots to use paralytics and keep the patient on volume control, because the original study who did it kept them on volume control. And I keep my voice, like I lost my voice yelling at the people saying, please don't be an idiot. This is a study. The study will be idiotic to do two changes, you know, that's why they do. But for real life, if you're on volume control and you paralyze somebody, benefit from the pressure control and the inverse ratio, because that's the only time you can do it, right? A reversal of muscle relaxants, you use neostigmine, 4 milligram, and Robinol, 0.8 milligram. This is together in the same. In fact, the anesthesiologist put it in the same syringe. That's how scared they are of. Oh my God! I'm gonna cause. Okay, what's the problem with neostigmine? Neostigmine is what? Is one of the choline esterase inhibitors, and choline esterase breaks what? Breaks the acetylcholine. So if you have something that breaks acetylcholine and inhibits that, then you have acetylcholine storm. And when you have acetylcholine storm, it has two effects: the nicotinic effect remember physiology professors, and the muscarinic effect. Right? The nicotinic effect is obviously the ganglia and stuff like that, and the muscles. That's the nicotinic effect. That's what we want. But it also gives you the muscarinic effect. You can't get rid of it. So that's why we have to combine it with Robinol. Otherwise, the patient is going to have a cardiac arrest. With neostigmine alone, you have a cardiac arrest. When we use neostigmine for the other indication, which is Ogilvie syndrome, what do we want? We want the muscarinic or nicotinic. For that indication, we want the muscarinic effect because we want the bowel to move, right? So for that other indication, we use neostigmine alone, and we use only 2 for Ogilvie syndrome. And we have the atropine on the circuit, like this. If the heart rate goes down below 55, we inject it. And that aborts the neostigmine, it's like as if you didn't give it.
Ogilvie syndrome, colonic pseudoobstruction.
Yeah. One resident here was actually, I said, wow, we're giving so much neostigmine, you guys are really used to it, I love it. And it turned out that every neostigmine is given atropine with it. Like, we didn't give it. We didn't give it. All right, you can give dopamine with it or dobutamine with it, but it's not that. All right, that's it, professors. Any questions?
Onset of action for VEC and CIS.
Oh.
Because we don't use those for RSI. I'm assuming it's because they have too long to intubating conditions.
Excellent question. 2 to 3 minutes?
Yeah.
And 2 to 3 minutes. But let me tell you a trick. If you don't have racuronium, or if you don't want to use it, and you don't want to use sucks for a contraindication or something, it happens to me a lot. Somebody brought the kit, and that's the only thing in the room, and it has vicuronium in it. So you know what you do? There's something called preempting, I forgot the name, 1/4 of the dose. So you give like 2.5 milligram before you prepare everything. And just 2.5 milligram, prepare the oxygen, prepare whatever, blah, blah, blah. And then when you go with the 7.5 milligram, it reduces to 1.5 minutes. Right, so that's a potential. Another potential is that you just give the whole dose immediately before propofol. So you're seeing the patient, everything is ready to be intubated, give the whole dose of vicuronium. It takes 2 to 3 minutes to paralyze the patient. So the patient is still looking at you, still moving, whatever. 1 minute later, you give the propofol. And that's when, within a minute or minute and a half, you'll be able to intubate the patient. So you can still use RSI with it, but not really the best to do.
And any specific reason that you would have to use propofol in that situation for your
No,
induction
you
agent,
can
or
use
just whatever your
any
induction
other.
is? Okay.
Yeah. I love it. Thank you very much.